Piyali, 25-year-old beedi rolling worker, went to her village doctor for relief of acute pain in both her wrists, fingers, and elbows. She also complained of palpitations at times. Her doctor went into action by advising tests for rheumatoid arthritis and gave her some analgesics. Piyali works for long hours, cross-legged and bending forward to roll beedis with her nimble fingers as fast as she can. This was obviously likely to be an ergonomically caused work-related musculoskeletal disorder. The doctor could have asked her, "What work are you doing?" to be wiser about the diagnosis. Effective history-taking has long been identified as a core discipline in treating patients. Spending more time compiling a good patient history has been known to provide the most benefit as compared to long physical examinations and expensive laboratory tests. Collecting an incomplete history can affect initial therapy and all subsequent decisions for treatment. Therefore, it is essential that primary care physicians ensure that neither the patient nor the health system is unduly burdened by deficient history-taking. Primary care providers and family physicians can play an important role in improving the recognition of occupational disease, preventing progressive illness and disability in their own patients, and contributing to the protection of other workers similarly exposed. This role can be maximized if physicians raise their level of suspicion for workplace disease, develop skills in taking occupational histories, and also learn basics of advising prevention. Industry profile. The total number of persons involved in beedi making in the country is estimated at around 40 million. The beedi is a rolled tendu leaf in which tobacco flakes are filled. It is an Indian cigarette. Some studies estimate that beedi smoking constitutes approximately 85% of the total tobacco consumption in the country, while others put it between 61 to 73%. The beedi industry operates in 17 states, with over 95% of its production concentrated in 10 states and employs approximately 3.4 million full-time workers. A further 0.7 million were part-time workers. Some sources from the All India Beedi Industry Federation put the figure of the total number of persons employed in beedi rolling at almost 8 million. Beedi workers were also among the lowest paid employees in India. The industry offered only 0.09% of all compensation provided in the manufacturing sector, organized and unorganized. The beedi workers may earn minimum wages or negotiated wages, which means a lower wage than the minimum government prescribed wage. This keeps beedi workers in penury, while tying their daily wage to punishing targets of about 1,000 beedis a day, causes ill health. West Bengal, Maharashtra, Andhra Pradesh and Karnataka are among India's top beedi-producing states. In West Bengal's district Murshidabad, beedi rolling is pretty much the only livelihood. Distribution of workforce. Beedi industry is predominantly a home-based industry in India. This is largely because manufacturers have significantly shifted from factory-based to home-based production, in part to deter beedi worker organization and to avoid appropriate implementation of working condition and welfare laws. However, cooperative societies have also come up wherein workers are working together in beedi making process. Irrespective of whether they work from home or in small manufacturing units, women form the bulk of the workforce engaged in the making of beedis. There are many reports of children, sometimes as young as 5 years old, who are also engaged in beedi rolling work. Some estimates peg the number of women employed to between 60% to 70% of the workforce and children to be around 15 to 20%. Beedi workers are largely poor and illiterate. There have been reports wherein beedi workers, of whom quite a large number are women, are treated like bonded laborers who invariably work anywhere between 10 to 16 hours daily and live under deplorable conditions. Characteristics of work. The occupational life of beedi workers are characterized by low wages, piece-rated remuneration, lack of social security, and absence of organization. The beedi workers are in the clutches of contractors and subcontractors. The contractors are the suppliers of raw materials as well as collectors of the final products. Most workers are given tobacco to roll at home. Protective measures such as masks and gloves are unheard of, and soon enough they suffer the ill effects of exposure to tobacco flakes and dust. Most workers live in one small room where they do the beedi work as also cook and sleep. Awareness of the beedi rollers regarding adverse effects of their occupation and safety measures that have to be taken is very poor. Working for long hours. Many workers work for more than 8 hours a day to meet their minimum targets. In urban areas, there may be workshops or organized beedi making units. Many of these places are small, airless rooms, often without windows, where beedi making workers are crowded together. They usually sit on damp mud floors. Payment is almost universally made on piece rate basis. Many smaller workshops are open day and night. Regular intervals for meals and weekly holidays are generally non-existent. Health problems and disease patterns. Hazards related to health and safety can be categorized as those occurring due to the nature of work and those occurring due to exposure to tobacco. Ear, throat, and lower respiratory tract infections along with respiratory cancers and tuberculosis. It has been observed that exposure to tobacco dust leads to a 6-fold higher incidence in respiratory complaints such as cough and breathlessness. Many women workers suffer gynecological problems and pregnancy complications. Anemia, musculoskeletal disorders, and fatigue are also conditions that predominantly affect beedi workers. Dermatological conditions. Irritant contact dermatitis. Occupational dermatitis. Causative source. Mainly fingertip thickening due to contact with tobacco dust and tendu. During rolling of beedi, nicotine of tobacco powder comes into direct contact with the skin and becomes absorbed through the skin into the blood. Nicotine is harmful to the body, and since it is carcinogenic in nature, it can cause cancer during long exposure. Injuries and musculoskeletal conditions. Pain. Acute shoulder pain, neck pain, and back pain. Causative source. High intensity of shoulder, back, and neck pain is due to sitting in forward-leaning posture and bending head and neck downward for prolonged hours without any back support and arm rest. Knee, chest, elbow, and wrist pain. Causative source. Postural problems related to sitting on the floor, either in cross-legged position or with one leg folded and another leg extended position, or with both the legs in extended position, sometimes sitting for long periods on the floor with both the legs folded behind at the knee. Respiratory conditions. Allergic bronchitis. Chronic obstructive pulmonary disease. Causative source. Inhalation of tobacco takes place during blending operation. Blending is usually done in a small room without using any mask, and the blenders directly inhales fine dust particles of tobacco. Asthma. Cough and breathlessness. Causative source. BD workers are 6 times more likely to suffer from respiratory tract affections and infections than other populations. It has been observed that in most cases of BD making at home, the passive recipient is the child due to lack of hygienic awareness in the mother. This is mainly found in cases where the mother feeds her child without washing her hands properly. As a result, the child also becomes affected by tobacco and develops related ailments at an early age. Tuberculosis. Causative source. Unhygienic habits, working in cramped up and unventilated spaces, and vulnerability to lower respiratory tract infections contributes to the incidence of tuberculosis. Circulatory conditions. Hypertension. Causative source. Systolic hypertension may occur due to coming in constant contact with tobacco dust. Gynaecological and obstetric conditions. Menstrual disorders and leukorrhea. Excessive bleeding during menstruation, irregular and painful menstrual cycles, leukorrhea. Causative source. Poor diet and anemia may be contributing factors. Low birth weight. Causative source. A number of factors may contribute to this condition, mainly nutritional deficiency inducing iron and calcium, fatigue, poor hygiene, and protective measures taken, and the direct influence of tobacco. Ear, nose, and throat or ENT conditions. Otitis externa and otitis media. Causative source. Unhygienic work conditions and contact with tobacco dust and flakes. Behavioral conditions. Insomnia and anxiety. Causative source. Insecure feelings and suicidal ideas. Poor socio-economic conditions and fatigue may be the problems. Ideal recommendations for health, safety, and welfare of BD workers. ASHA workers as well as healthcare workers and Anganwadi workers can sensitize the pregnant women who are BD rollers about the harmful effects of tobacco and can also raise awareness about safety measures such as washing hands, wearing mask and gloves, cleaning floor and storing tendu leaves in dry area. The Indian government has initiated several legislations to ensure safety and economic security of workers in the BD industry. The various measures implemented by the government are: 1. BD Workers Welfare Fund Act, 1976, meant to provide basic benefits such as healthcare, education, insurance, housing assistance, scholarships, drinking water supplies, and provides hospitals and dispensaries across the country for BD workers. 2. BD Workers Welfare Cess Amendment Act, 1976. Under the cess collected through excise duty of manufactured BDs, workers receive benefits from a government fund. However, it is applicable only to workers who have a valid ID card and work for registered companies manufacturing more than 2 million BDs per year. 3. Employees State Insurance, 1948, provides health, medical, and cash benefits for sickness, maternity, employment-related injury for employees making less than the stipulated amount per month, as well as their dependents who are also entitled to pensions in the case of death or employment injury. General Principle of Prevention of Occupational Diseases and Injuries. Preventive interventions require strategic contribution and efforts from government through occupational health and safety policy and legislation, cooperation from employers as well as workers, and advice from medical professionals. Occupational diseases manifest after long latency period from the time of exposure. There are challenges to establish and declare that a disease is due to hazard at workplace. Elaborate guidelines for management and prevention of occupationally caused diseases is beyond the scope of this documentary, as currently there is no mechanism for doctors to enforce their recommendation without a statutory backing. We therefore give general principles of prevention. Preventive measures should be designed and implemented at 3 levels of prevention. 1. Primary prevention aims to reduce the occurrence of disease by eliminating the cause of disease. For example, use of benzene-free solvents or solvent-free paints to eliminate the risk of carcinogenicity or reducing exposure to safe levels that prevent it from causing damage. For example, reducing noise at its source to levels that do not cause noise-induced deafness. 2. Secondary prevention to identify and treat health problems as early as possible, often before symptoms have developed, in order to take corrective action. For example, regular audiograms among workers exposed to high levels of noise in the work environment. 3. Tertiary prevention aims to avoid complications of and disability from illnesses and injuries and/or to provide rehabilitative and palliative care. It aims to minimize the consequences in persons who already have disease and depends on appropriate treatment. We expect that the primary care physicians, already well versed with clinical knowledge for management of the occupationally caused health conditions. To learn more about detailed clinical perspective, treatment and prevention and control, please refer to e-book or printed version of BOHS for Informal Industry, Manual for Primary Care Providers. So when your next patient with any of the presenting symptoms we described earlier comes for treatment, please don't forget to ask him the $1,000,000 question. What exactly is the nature of your work?